appreciate your spending quite a lot of your own time this meeting. I'm going to start not in Glasgow, but in South Wales, where I was last weekend, for our 50th wedding anniversary of two friends and colleagues of mine, Mary and Julian Tudor-Hart, who some of you may have heard of. And quite a lot of what I'm going to talk about has its origins in time that I spent there as a student and a research fellow almost 30, 40 years ago. I went because I thought he was talking about the future, and actually he still is talking about the future. And one of the things that's very difficult is to convey to you the special nature of that experience. And there's one quick way to bring it. On the first day that I arrived, a Friday evening, I was taken to the pub with the research team. And whilst they were chatting about plans, what's happening here? This was my first Friday night, and you can imagine I felt I was in a special place. Special in lots of ways, which will become obvious as I go on. Decisions are sometimes based on evidence, usually based on experience, always underpinned by values. And the task of academics and others is to produce the evidence, draw on the experience, distill the values. And I hope my talk is going to reflect something of that, draw it on a wide range of sources. The first being Scheherazade, who had the task of creating a new story every day. Her life depended on it. And eventually she produced over 1,000 stories. I'll explain the relevance of that shortly. My talk is in two parts. The first part is a mosaic, where I'm simply ranging across the ground, trying to establish some ideas and context. And then I'll get into a narrative as I explain the Deep End project. So there'll be a few jumps, and this is probably not one of them. Arthur Miller, famous as a playwright, Crucible, All My Sons, Youth and Bridge, several, the Salesman, Death of the Salesman, the husband of Marilyn Monroe, progressive, the father of a son with Down syndrome who he put into an institution and never saw again. Something that seems astonishing to us now for a progressive man, but something that was normal at the time. It was normal to do that. And it's within living memory. Top left is a place called Lennox Castle near Glasgow, which wasn't a prison like Colditz, but sometimes seemed like that. It was where people with learning disabilities were put away, visited by their parents. And you may have had institutions like that too. This particular one no longer exists. It was demolished, dismantled. All the resources that were concentrated in that institution were redistributed throughout the community with an entirely new set of relationships. The thought experiment that we might come back to is what other concentrations of resource need to be dismantled and redistributed to new sets of relationships within the community. Some are coming from the UK. I always show this slide. It's the two things you must never leave the UK without. First is your passport. I'm not sure if anyone speaks Mandarin in the audience. Is there? Who knows what the... Can you explain what the Chinese figure means?
English?
Yes. Humility. I'm not pretending for a minute that I'm bringing you answers or lessons. I'm just bringing an example and take from it what you will. One thing that we do have in common is the rise of non-communicable disease. If you're not living in sub-Saharan Africa, we're all in that same boat of the inexorable rise of non-communicable diseases as captured in the UN summit, where the principal policy responses were public health measures to address smoking, salt, obesity, alcohol, and some clinical measures applying evidence-based medicine to reduce cardiovascular risk. Some of these interventions are about preventing things at the early origin, whilst others are dealing with them once they're established. So much of my talk in terms of inequalities is going to be about inequalities which are established and what we need to do to mitigate them and to prevent them getting worse. And that's a complementary, important, but rather neglected strategy compared to the more popular one of trying to go upstream and to prevent inequalities through the social determinants of health. We need both approaches. One of the weaknesses of the UN summit and the public health lobbying that went into it was the absence of a primary care voice. As this letter from Jan de Messner, again, and others made clear in letter to the last. And their argument principally was that the public health approach to NCDs was too vertical, disease-based, specialist-led, evidence-based. Whereas the kind of systems that we're going to need to deliver the kind of care that will be necessary for non-communicable diseases is more horizontal, integrating all we know around the care of individual patients and communities. So the horizontal-vertical tension is new. The review papers are 60 years old, and it reflects the fact that left to its own devices, health systems will always tend to centralize, specialize, and in some cases privatize. And these are directions that we just mustn't go in if we want to address future problems. Now, of course, some people don't require help from the health system to live long and happy lives. They should get on with it. But in Scotland, and perhaps here, there are 6 populations who account for part of the compact of the health system. They certainly do require a different type of care. Almost a year ago, the London Olympics was the first occasion in which a national health system was celebrated at the opening ceremony. It was a nostalgic, hospital-based look of the past, celebrating Bevan's wonderful clarion call that illness is neither an indulgence for which you have to pay, an offence for which you should be punished, but misfortune, the cost of which should be shared by the community. I think we all agree that's still true. But we need not just to be looking backwards, we need to be looking forwards at how these principles can inform our solutions to future problems. Health systems are not businesses to make profits, although they can be. They're not public utilities like gas and broadband to produce customer satisfaction, though they can be. They are, in essence, social institutions founded on mutuality and trust. And never more true, never more important. And universal coverage is necessary but not sufficient. Countries without it are labouring, but it's not sufficient because even with universal coverage, the absence of financial barriers to care, you still have the inverse care law. The availability of good medical care varying inversely with the need for it in the population served. It was my friend and colleague Sheila Hart who first coined that over 40 years ago. Universal coverage is not enough. Universal coverage on its own assumes that the world of healthcare is flat, when it's actually built on a slope, as I'll illustrate. "40 years ago, the veteran study showed that hypertension could be reduced, strokes prevented, and lives prolonged. A whole lot of other studies bolstered that. It showed that medicine could make a difference. And Gordon Wright that introduced an elephant into the room, which was that if healthcare could make a difference and it was applied inequitably, it would reduce inequalities, despite our best intentions. And I don't think that's fully recognised yet. Dependent GPs argue that the health service should be at its best where it's needed most, or else it will widen inequality. Now there's a challenge. Another issue where I think we have common cause is the too many cooks syndrome. I have another way of looking at it, which is that we've got too many hubs.